we can just start doing some housekeeping if you want to share. Yeah. So welcome everybody to our first CEQIP quarterly COP meeting. I'm really excited about this and to learn from how it goes today and get feedback and find out what you guys want to learn about or talk about moving forward. So a bit of housekeeping. This is set up as a meeting. So it looks a little bit different than the CEQIP launch webinar. You will have a chance in the Q&A portion to raise your hand. It's under the reactions button on your bottom of your toolbar there. And there's a raise hand. So later when we do the Q&A, you can raise your hand and we can call on you to unmute and you can ask your questions. So that should be good. But we will ask that in between when we're not doing the Q&A, if you just stay on mute so that we can have good audio for our speakers. That would be appreciated. And you can move to the next slide, Melissa. Did I introduce myself? My name's Janine. I'm a lead for OHT implementation and I work on the Collaborative Quality Improvement Program. And I have a few team members with me today. Melissa Chan, who's helping with the slides, who helps with CEQIP. Maggie, who's going to do the land acknowledgement this morning, who works on CEQIP. And we have some really excellent speakers here today. And we're going to be talking about applying a population health management improvement lens to the collaborative quality improvement plans. And I think before I get to introducing the agenda and the rest of our speakers, we're going to have Maggie do the land acknowledgement. So if you want to go to the next slide, Melissa, and I'll hand it over to you, Maggie.
Thank you, Janine, and hi, everybody. I want to open this virtual meeting by acknowledging the land that I'm speaking to you from. Sorry, just sort of move over here. From today, I'm currently located in Toronto, and I respectfully acknowledge that this is the traditional lands of many nations, including the Anishinaabeg, Wendat, Haudenosaunee, Mississauga, and the Mississaugas of the Credit First Nation. These territories are currently covered by Treaty 13 with the Mississaugas of the Credit and the Williams Treaties. Today, Toronto is still the home to many First Nations, Inuit, Métis, and urban Indigenous peoples from across Turtle Island. I was born in Toronto and have lived most of my life in the GTA. However, my family immigrated to Canada as European settlers from Azores, Portugal. I think it's important to reflect and acknowledge that the arrival of the European newcomers radically changed the lives of Indigenous people. While I didn't grow up with the recognition, I now recognize today the colonial legacy and long-standing history of systemic racism that Indigenous people have endured and continue to face in Ontario and Canada. I'm eternally grateful to the Indigenous peoples for caring and sharing these lands and waters with those of us who are newcomers. I'm fortunate to live on the waterfront and enjoy many outdoor activities near Lake Ontario. Being near the water has given me an appreciation of the importance of caring for the land and respecting our waters. To Indigenous peoples, water is a vital and sacred element that holds spirit. In many regions, Indigenous peoples live with insufficient access to high-quality, safe drinking water. My own commitment to reconciliation is to continue to enhance my knowledge of the determinants of health and to reflect on how my work at Ontario Health can contribute to improving the healthcare experiences and outcomes for Indigenous peoples. Thank you.
Thank you, Maggie. Okay, so I'm going to launch an entry poll, and Melissa, you can move on to the next slide because I'll talk a little about the agenda while we're doing the poll. So the polling question is just one. We just want to get an idea of who's here today. Which OHT are you a part of? It's short answer, so you can type it out in there and submit your answer. So today we've done the land acknowledgement, we've done the entry poll and some welcomes. We're going to then have Mike Hindmarsh, who's one of the RISE coaches. You may have come across him before. Thank you, Mike. Kind of do sort of like, I want to say, a mocked up example, walking us through using a population health management and data-driven approach to a collaborative quality improvement plan. And then we'll have some real life examples from some OHT speakers that have used this approach. So that's going to be really great. And I'm going to let each of them sort of introduce themselves more formally when we get to their part of the talk. And at the end, we'll have some time for Q&A. And then we'll do a wrap up and just review again some of the general CEQIP supports that we have for you guys. That's the plan for today. I can't see, did you guys see the poll? Because it doesn't look like the answers are coming in. You do? Okay, that's good. Then I will end the poll. And we can move to the next slide, which shows all the great speakers that we have here today and which OHTs they're from. And without further ado, I'm going to hand it over to you, Mike.
Very good. Welcome, everyone. And as Janine pointed out, I'm going to give you a quick example of how you can apply population health management to your CEQIP work. Many of you have seen the 5-step population health management model that we've talked to you about. I see a lot of familiar names on the webinar today. So if you haven't seen this model before, reach out to me afterwards and I can certainly give you more information about it. Let's go to the next slide. It's important to recognize that when you're doing population health management, all of you have chosen priority populations as part of your OHTs, and that these CEQIP populations are simply subsegments of your larger priority populations. So this CEQIP indicator of mental health in the first presentation in the ED is simply part of your mental health priority population, so on and so forth. So I just wanted to point out that these aren't new populations, they're just subsegments of the larger populations that you're already working on. Let's go to the next slide. So where do you find data about your CEQIP populations? You've all been doing this for quite a while now, and you've used a variety of different data sources, and your coaches have helped you find data. The new OHT dashboard, newish dashboard, has some great data around each of the indicators for your CEQIP indicators. So this is an example of first contact for mental health issues in the ED. This is all OHTs together, but you can pull out your particular OHT. And as you'll see on the slide, it will show you over time how the number of people coming into the ED is changing over time. It will give you a breakdown by gender, it'll give you a breakdown by age, show you when they're showing, is there more people coming in after hours or on weekends and during regular time. And then in that little gray area there, you'll see that it gives you the various diagnoses that people have when they're coming in to the ED for mental health issues. And that in this case, across the province, the top one is anxiety and dissociative disorders, depression, which a lot of you have learned already from some of your hospital data when you were querying hospital information. So I urge you to go to the dashboard, take a look at this. This is really helpful. On the bottom part there, it will also break it down by hospital and the people that are coming in by the hospitals in your OHT. Let's go to the next slide. So with that in hand, you want to start thinking about the next step of population health management, and that's how to segment that identified population. And I just used an example here. So again, if we use our segmentation pyramid that we've talked about for the last couple of years, at the bottom, what you would have perhaps would be all people with anxiety and depression presenting in the ED. And maybe you've used Inspire data or data from primary care EMRs or hospital data. The next sort of rising risk group would be the people that are presenting in the ED for the first time with anxiety and depression. And I just showed you an example of getting that data from the OHT dashboard. You would have a higher risk group of people that are presenting with anxiety and depression that presented for the first time but are now presenting more than twice a year. And then you can get into your high users. These are people that are multi-comorbid with complex mental health issues. So this is just one example of how you might segment the data. You might have different ideas about how you want to do it. but it's important to segment that data because as you see on the next slide, you might want to just target a particular segment of the population for your CQIP indicator, or you might just be targeting them based on other work that you're doing around mental health improvement. And you're going to see an example of that from Brenda Vollmer from Kitchener-Waterloo. But let's say you decide that you're going to target these two segments, the people presenting for the first time and the people that are also presenting more than once. What do you need to know at this point? You need to know maybe perhaps what are the CTAs that they presented? Were they urgent, non-urgent? Explore their attachment status. Do they have a primary care provider? Your working group might want to sit down and say, well, why are these folks showing up here? You can use fishbone exercises or the 5 whys. You can look at their FSAs, their postal codes, and see if they're coming from areas of material deprivation. Are they racialized, or are there other inequities in this group? And then start process mapping. Well, what actually happens in the ED when they come there and what happens at discharge, so that you get a good sense of why they're coming, what are they receiving, and then what happens to them on discharge. So you can start thinking about how do we improve this process to not only keep them out, but also to keep them from coming to the ED, but also to make sure that they're receiving good care. Let's go to the next slide. So you come to step 3 of the care model design, and what do? You look to the literature to see what are good interventions, evidence-based interventions for working with anxiety and depression upstream before they come to the hospital. What are the best practices in other provinces or countries? What are other OHTs doing? Because all of you are working on these. What are other primary care providers doing? And then, of course, you have the expert supports like the mental health community or center of excellence that is providing guidelines for this. Let's go to the next slide. So here's just an example of how you can start thinking about a care model and testing ideas to see how would I build this model in a way that it's ready to be implemented. We don't want to jump to implementation, obviously. So you can do a driver diagram and look at what, performance data that suggests why the people are showing up in the mental health for untreated depression, anxiety. What's the performance data suggesting from primary care in terms of people not being screened? And start doing some simultaneous tests of change. You could test in one hospital with one ER nurse who is screening or who could screen for depression when the patient comes in and send the positive results to the primary care provider. You could at the same time test with one primary care provider with patients after an ER discharge to see if someone followed up with the patient. You can have 2 primary care providers, one in a family health team and one in a solo practice, pull patient data from their EMR with multiple chronic conditions, and at the next visit, schedule not only their chronic care, but make sure that they are getting regular check-in visits and they're screening for depression. So these are all ideas about how to work upstream to manage people's anxiety and depression, or at least identify it, so it's not getting identified in the hospital. Let's go to the next slide. Then you come to step 4, implementation and reach. You've built the model, you've tested it, so it's bulletproof. Now you have to have an implementation plan for how do you spread it throughout the whole OHT. And that implementation plan needs to be as considered and tested as much as the care model that you're designing to spread across the region. Next slide. And then once you've done the implementation and it's now built into the way the OHT does work, you want to make sure that you have an evaluation system that monitors the implementation on an ongoing basis, making sure you don't fall back to the old way of doing things. You measure the quadruple or quintuple aim and use some of those as your indicators, as well as your CQIP measures to monitor and evaluate the care model now that it's been implemented. Next slide. So who will be responsible for that ongoing monitoring and evaluation? It's got to be part of the OHT back office. Uh, make sure the performance metrics are set and data can be easily collected. And again, as I said, you want to make sure it's the monitoring and evaluating, make sure that the model is sustained and you don't go back to the old way of doing things. Last slide. These are just some questions. I'm not going to go through them, but these are questions you can ask yourself as you're going through the population health management process around each of the steps and how it applies to your CEQIP. So you can sort of use it as a how-to guide if you find it helpful. And I hope I'm done, and I hope I'm done on time, which I'm just checking.
That was great, Mike. And I think now, thank you for doing that and walking us through that example. And now we're going to be moving on to you, Brenda. So if you want to introduce yourself to the group and talk about what KW4 OHT has done.
Perfect. Thanks, Janine. And good afternoon, everyone. So my name is Brenda Vollmer, and I'm the Director of Project Management and Project Supports at the KW4 Ontario Health Team. So the project support function of my role includes things like quality improvement, performance management, and planning functions, such as the development of a strategic plan. So it is such a pleasure to be with you here today and to have been asked to present alongside Mike, our wonderful RISE coach, on how we have applied a population health management approach when designing our CEQIP work. So I'd also like to recognize Rebecca Petrosivic, who is also on the call today and has been instrumental in helping our OHT with moving this work forward. Next slide, please. Okay, so let's start with who we are. So for a quick overview, the KW4 Ontario Health Team is part of Cohort 2, which means we became an approved OHT in October of 2020. And KW4 represents the cities of Kitchener and Waterloo and the 3 townships of Wellesley, Wilmot, and Woolwich. We border 2 other OHTs, Guelph Wellington and Cambridge North Dumfries OHT, who we work closely with, as many of our partner organizations provide services in all 3 regions, and patients receive services across all 3 OHTs. We have 41 partners from different sectors and areas of focus. We at KW4 OHT recognized early on that we needed to take a broader view of health and are fortunate to include both the City of Kitchener and the City of Waterloo and the region of Waterloo, the University of Waterloo, local settlement agencies, social service agencies, as well as other partner organizations. And taking this broader perspective is really key to our success as an OHT. And it is especially important as we take a population health management approach. Next slide, please. So our population is quickly approaching 500,000 people. We are growing at a faster pace than Ontario and Canada. And between 2016 and 2021, our population grew by just over 43,000, with recent immigrants making up more than half that growth. So this equates to a growth rate of 10.9% as compared to 5.8% for Ontario and 5.2% for Canada. Next slide. So with such a large population, it was important for us to identify which subpopulations we wanted to focus on. And as Mike noted, this is the first step in the process. So a lot of work around addressing health inequities is happening at KW4. So when we looked at our health data, we continue to see that 4 neighborhoods that are disproportionately impacted. So these neighborhoods account for only 18% of the population, but almost 35% of our ambulatory care sensitive conditions best managed elsewhere, almost 32% of our ALC days and 29% of our ALC cases, 30% of our inpatient days, and almost 44% of our frequent ED visits for help with mental health and addictions. And as of September, these neighborhoods also accounted for 30% of the patients registered with Healthcare Connect in hopes of finding a primary care provider. These neighborhoods also have a higher proportion of marginalized populations, including Indigenous peoples, visible minorities, and newcomers. Next slide. So it's therefore not surprising that when we looked at cancer screening rates, we found that these same neighborhoods had the lowest rates and were 14 to 17% below screening rates of the best performing neighborhoods in KW4. So we therefore decided that for this fiscal year, we would focus our improvement initiatives on this subpopulation. Next slide. So the next step was really to understand the size of this subgroup. So by applying this lens, we were able to narrow our focus from a population of almost 450,000 to that of 91,000 based on the neighborhoods where the patients reside. Then by looking at those who were eligible for the 3 cancer screening tests based on age and gender, we were able to further reduce our focus to between 10,000 and 30,000 people, depending on the test. And then we looked at the frequency of testing. So whether it be every 2 or 3 years, we were then able to perform an order of magnitude calculation on how many people would be eligible for testing each year. From there, we calculated how many people we would need to reach in our priority neighborhoods who would otherwise not participate in screening to reach our target that we wanted to reach. And this final calculation was important to understand before we began to consider which of the improvement initiatives we would move forward with. Because if they weren't going to reach enough people, we weren't going to move forward with them. Next slide. So now that we had identified the population we were targeting, we moved on to the second step of understanding needs and risks and barriers. And this took many forms. So we held a focus group where 52 people joined us, and this included 46 people representing 19 different organizations, as well as 6 patient, family, and community representatives. At KW4, we are committed to co-designing solutions with community, and therefore we made a concerted effort to ensure that their voice was a key part of our focus groups. The purpose of the engagement session was really to identify barriers and enablers, as well as to brainstorm solutions. We also looked at the patient journey from when the patient receives a notification letter from CCO to when they receive the results. And we looked at this for both attached and unattached patients. And so this helped us identify screening barriers as well as enablers for both patients and providers. Next slide. So following this, we moved on to step 3, where a smaller group met to prioritize recommendations and develop implementation plans. And so this resulted in our change concepts that were identified in our CQIP. At this point, we also drafted a logic model. Next step, or next slide. So we then moved on to step 4. So we began with 2 areas of focus. The first was to reduce the admin burden related to cancer screening, which primary care providers were experiencing. We built on the success of East Toronto, where they had implemented PoppyBot, which is an automated solution or virtual assistant that identifies patients overdue for cancer screening, and then stratifies the identified patients into priority groups, and then automatically initiates patient follow-up. Implementation into our first pilot clinic in KW4 is in progress right now, with a planned completion date of March of 2024 for this first pilot. Next slide. Our second area of focus was to increase patient knowledge and awareness through a marketing and public outreach campaign focused on addressing the barriers and misconceptions of patients in our priority neighborhoods. The campaign includes culturally appropriate messaging available in multiple languages. This included updating our Regional Cancer Center website and adding translation capabilities, ads posted at transit stops in our priority neighborhoods, posters at community centers, health clubs, grocery stores, booths at various community events, and hosting information sessions as well. Next slide. So we have not yet completed the last step, which is monitor and evaluate. However, we have identified indicators of success as shown here. Just of note, we chose not to include these as custom indicators in our CEQIP, so we went with the indicators that were already in there. But we are really using these to, monitor our success on an internal basis. And then, so once this evaluation is complete, we will then determine how best to refine, scale, and spread these initiatives. So hopefully this example has helped to demonstrate how you can effectively apply a population health management approach with an equity lens to your CEQIP work. And next slide is just our info. So thank you.
That's great, Brenda. Thanks so much. And I'll encourage anyone who's wanting more information or to follow up with Brenda, or also use our CEQIP shared space where we've been posting slides from the sessions. There's peer learning templates on there, and that's a great place to share as well. So I think you guys can type your questions in the chat. We're going to have Q&A time at the end, but we're going to move now on to South Georgian Bay. And Sarah Grace, I'll let you introduce yourself.
Thanks very much, Janine. So as mentioned, my name is Sarah Grace Bevanek. I'm the project manager and the backbone staff team lead for the South Georgian Bay Ontario Health Team. Thank you very much for the opportunity to come and present this afternoon. There's already lots of great examples of CEQIP segmentation, and hopefully this will provide another example specifically for the frail older adult population. So our OHT in South Georgian Bay is part of cohort 2 and has an attributed patient population of just over 60,000 people who primarily live in the Collingwood, Wasaga Beach, Clearview, and Blue Mountains region. But as shared with others, this region and population is growing at a very rapid rate, with Collingwood and Wasaga Beach both recently named as some of the fastest growing communities in Canada. So with that brings a lot of significant population changes as well. Oh, sorry, you can stay on that slide. Thanks. So within our population, we have a very high attachment rate to primary care and a significantly higher percentage of older adults age 65 and over compared to the provincial Ontario average. So due to this data showing the higher prevalence of older adults, our initial population of focus chosen by our OHT was those frail older adults identified to be supported through our OHT based on our integrated care priority that you can see there around population-based integrated care. So once we defined at a higher level that we wanted to focus on that population, we really wanted to better understand what their health needs are to ensure that they're able to be supported in the community to ultimately reduce their acute care utilization and ultimately our local ALC days, which would be reflected in the CEQIP. Next slide, please. So through our CEQIP, as our OHT, we're really committed to working together to improve our overall access to care in the most appropriate setting, especially for those that are most vulnerable, with our older adult population certainly included in that. Through our CEQIP, our partners are really committed to co-designing the future of older adult care in South Georgian Bay and collectively recognize the need to focus on this population. So as part of our CEQIP ALC indicator, with the support of our fantastic RISE coach and her team, we've set up numerous process indicators over the last few years, including the use of the Clinical Frailty Scale, or CFS tool, to start to stratify our population, specifically using it in primary care to really understand what frailty means. Frailty is a very hard term to define and understand from a population health perspective. So we chose to use this evidence-based tool to really understand what the needs of this population is relative to the score on that tool. There were quite a few change ideas completed in the 2023-24 fiscal year to complete our broader ALC goal, with one of them using this data and evidence-based tools to proactively identify older adults who are living with or at risk of frailty to determine the level of care that they need to support aging at home and in the community with the right care at the right time. And we found that we did a bit of an assessment across various different tools and found that the CFS was really the best one to start with, at least in primary care, to ensure that everyone's connected with the warm transfer to the most appropriate services that they need. Next slide, please. So the target population for this change idea as part of our overall ALC plan is older adults 65 and older who live in South Georgian Bay or have a physician in South Georgian Bay who are at risk of frailty, who would benefit from this support with their physical health, mental health, and or the social determinants of health as well. And we specifically wanted to ensure that all of those domains were addressed, and the CFS tool really does look to those various domains of health overall, as opposed to just focusing on the physical health, recognizing that this population certainly is impacted by those social determinants of health as well. The success of this initiative is really due to our strong partnerships and collaborations through the OHT with some partners that you can see listed here, again, representing that holistic view of health across the physical, mental, and the social supports. Next slide, please. So the objectives of this change idea were, as I mentioned, to use a evidence-based tool. So in this case, we actually took it one step further to make sure that it was embedded into our TELUS PS Suites EMR. We're very fortunate that we have one EMR instance that's used by all of our primary care providers. So we really wanted to use that as a bit of a jumping point to start to embed a tool right in the EMR. To then be able to provide primary care using this tool with a list of the appropriate community-based resources and e-referral destination based on their patient's level of frailty identified by the CFS. So it is, for those of you that are familiar with kind of the EMR workflows, it's a custom form that we've made in the TELUS PS Suites EMR. And depending on where the primary care provider selects that the individual falls on the CFS scale, the appropriate resources are then listed. So older adults identified as low risk who are fit or managing well in the community are directed to additional preventative focus programs and services, really with the goal to maintain or improve their functional ability to optimize their health and prevent them from falling further into frailty. The next stage is for CFS levels 4 to 6, which are older adults living with mild to moderate frailty, to make sure that they have prompt access to comprehensive assessment. And through that, we did a bit of an inventory, if you will, or a current state of available programs in our community that would be able to support that population. And through this exercise, it actually enabled us to further grow our existing healthy aging program to include to support patients both that are attached and unattached. So this resource now, the South Georgian Bay Healthy Aging Program, is available for anyone that falls within the CFS levels of 4 to 6. And it's able to assess physical, cognitive, functional, and the psychosocial domains. And it's completed in partnership with the older adult, their family or their care partner and specialists, to really with the goal of preventing further progression of frailty. And the last level that you can see there is between 7 to 9. So these are typically older adults that are living with severe frailty. So we're really just wanting to make sure that they're supported with referrals to appropriate resources, including the Alzheimer's Society, home and community care support services, for example, for a long-term care application, and some local hospice community programs and supports as well. So after the form is completed and the individual is marked in terms of what their CFS score is, that's then transferred into a custom vital that's tracked in the patient's chart. And the primary care provider is able to pull that out as a graph or a flow sheet over time to be able to track their level of frailty and if there's been any changes, or alert them to any changes that may be occurring. Next slide, perfect, thank you. So a few kind of aha moments for us, if you will, of what worked well and some challenges along the way. So this project was really enabled us to use the OHT as an opportunity to bring partners together from across congregate care, physical health, mental health, social and community supports, as I mentioned, to really wrap around to support our frail older adults in the community with the primary care embedded resource. As a result of this, it really fostered collaborative conversation through our OHT to promote innovative ideas and approaches to a common challenge of connecting patients with the appropriate resources in the community using an evidence-based tool. And then as a team, we really worked together to overcome the challenge of the significant administrative burden being experienced by primary care. So we were really flexible with our project timelines and our approaches and made sure that we built the tools into existing workflows with primary care really as a key partner to inform that process. So that resulted in the CFS forms, searches, and graphs all being embedded into their current workflow. So that's all from me. If you have any questions, feel free to reach out anytime. My email is there, and you can also see some of our broader ALC work articulated through our CEQIP dashboard on our website. Thanks again.
Thank you so much, Sarah Grace. Really, really interesting work. We're going to move on. We have more great examples to share today. So now we have North Toronto OHT, and I'm going to hand it over to Holly and Inat to introduce themselves and talk about their work as well.
Awesome.
Over to
Thanks,
you.
Janine. And so, hi everyone, my name is Holly O'Para, and I'm a project manager sitting out of Sunnybrook, but largely helping out with the North Toronto OHT work with quality population health and all that kind of jazz. And I'm here today with Inette, who's a clinical manager at Baycrest, but also the project manager kind of overseeing the project that we're here to talk to you today about. And that's around the North Toronto neighborhood care team. On the bottom of the slide here, you can see our partners. So we have 10 partner organizations, as well as our patients, families, and caregivers, and our primary care providers coming together to help support and serve our North Toronto community. So if you could jump to the next slide here. A little bit of an overview of the North Toronto OHT and the North Toronto region. So we have about 190,000 people attributed to us through our primary care providers, but within kind of the North Toronto sub-region, which is, if we know our Toronto geography, kind of the 401 through to Sunnybrook Park, down to St. Clair, and then up the Allen Road, we have about 230,000 residents living within that sub-region. And so there's an interesting overlap between our attributed population and our geographic population, which does drive some interesting conversations at our OHT. But we can get more into that in a bit. Only 10% of our primary care providers practice in a team-based model. And I think similar to other regions in Ontario, there's rapid redevelopment happening with the Eglinton Crosstown. And so that's kind of pushing primary care providers out of our subregion, but then also expediting population growth. So in some of our neighborhoods within North Toronto, we are seeing about 100% or a doubling of population within the neighborhoods. And so we're here today talking about how we've used pop health data to help drive kind of implementation and care model design through our collaborative QIP. And so our year one kind of target population or priority population was frail seniors for a variety of factors, but mostly because of the prevalence of seniors. So we have about a 20% of our attributed population is over the age of 65. We do see higher admission rates to our core hospital of Sunnybrook, with I think around 60% of our admissions are for those folks over 65 or for older adults there. And there's also a variety of other reasons for that priority population. When we think about kind of drilling down into tangible groups that we can actually work with to help improve care models, we've identified 2 kind of high priority neighborhoods in North Toronto, again, from a variety of different population level data sources through the former Toronto Central LHIN data, as well as kind of HSPN and RISE, and those more aggregated data sources. There's higher rates of chronic conditions, lower attachment rates, things like that. And so really our focus for the North Toronto OHT work is in a neighborhood called Angle Mount Lawrence, and then another neighborhood called Mount Pleasant West, now been divided into 2 new neighborhoods. So from there, we've kind of developed or did a deep dive analysis into a variety of different population level data sources through IntelliHealth. So looking at the discharge abstract database, the ED visits, and the CHI population health grouper, as well as some Toronto Central LHIN socio-demographic data to focus from the big kind of 20% of our population to a more granular level of detail to kind of understand the different health needs of our seniors across those two populations. And what we found was that for a variety of different indicators, again, like ED visits, inpatient admissions, lower income, that kind of stuff, the data was pointing us to Toronto seniors housing buildings. And so we decided to kind of focus on trying to develop a model of care based or for these frail seniors within Toronto seniors housing buildings. From there, again, one step further down, using postal code level data in IntelliHealth, you can see a blurry screenshot here, but a whack of analysis went into understanding the different needs across those buildings as they show up as their own postal code to understand, again, health service utilization, who those patients are, their sociodemographic profile, to help prioritize building implementation. And, one might think, when we're talking about older adults, they're all older adults living in Toronto seniors housing buildings, so they might have a similar profile, but that's kind of not with what the data that we saw. And so really it was important for us to go through that exercise with the data to understand that different buildings have different needs, and so we need to adapt our care models for them based on what we see in the data. So once we got down to kind of the postal code level analysis to understand the needs and where we should be prioritizing kind of our initial implementation, our initial test of change within the buildings, we then brought this forward to our partners. And so we have over 10 partners kind of engaged in this work and providing services there. And so we brought it to them to say, this is what we're seeing on the ground, get their initial reactions and see if it aligned, and it did. But then the second thing we did was also bring it forward to the tenants actually living within these buildings. And so Inette and her team did amazing work on co-designing these models. So we interacted with over 200 tenants at these buildings in 7 different languages, looking at different varieties of door knocking, different lobby voting, co-designing sessions, but then also having them in our regular planning meetings and kind of through to the development of our change ideas. And so now I'll pass it to Inette to kind of walk through our test of change and the impacts that we've seen there.
Thanks, Holly. So taking that input from our stakeholders and the tenants, and of course the data, we came up with this change idea to develop and expand wraparound care and social support through neighborhood care teams to increase access to primary and community care, to address both the health and social needs of this population and ensure care in the most appropriate setting while working as one team. And you can see on the slide some of the of our objectives, but also some of the visuals of how we've built the model. I'll just highlight a few, 3 quick things on the slide. First of all, I would highlight that we took a very proactive approach to implementing this wraparound care by proactively screening for any health and social emerging needs among the tenants. And we developed tools and clinics for screening around that. Our model of care evolved and essentially landed on a 3 layers of service model of care, with the building starting with the building core team, which is located, it's clinicians located and embedded within the buildings themselves, and they serve as the first point of contact for those tenants and help them connect to the rest of our OHT kind of system and network. And they are supported by a broader network of providers from our partnering organizations and, of course, escalation support from the rest of the system to get engaged in care as needed. I also want to draw your attention to the graph on the right bottom side, which really shows how we took the data and the needs of the tenants as they expressed them and connected them to the actual design of the service on the ground. So we planned the content of the service and the intensity of the service that we bring to each building based on the level of need of the population in each building. So almost a microcosm in each building for population care there. Next slide, please. So on this slide, you could see some of the metrics that we've set out for ourselves. And on the right end, some of the progress to date. In the middle, there is a picture of one of our nurses in one of the medical rooms embedded within the Toronto Senior Housing. I would just highlight that so far from our data, from our baseline to date, we're already seeing a reduction of 15% in inpatient days, and that's a very promising progress. There is a lot of work still to be done, but certainly we're seeing the needle moving in the right direction. But to focus on the learning from this implementation so far, some of the challenges that we've encountered is, of course, the language barriers. A lot of those tenants are newcomers. They don't speak English as a first language, but some don't speak English at all, and we could see as much as 7 to 8 languages in each building. There is a growing complexity of the profile of the tenants coming into Toronto Senior Housing. I would say that lack of access to a common record continues to be a gap for us that we are working around right now, but also working towards. And that impacts our ability in coordinating care, some aspects of the care, but also in sharing information, and also limits at certain points our ability to link certain measures to the impact on the ground. Julio spoke before to the growing number of primary care clinics that are closing down in our area due to redevelopment, and that definitely increases and puts more pressure on the team. And no doubt that additional investment is needed in allied health and community supports to scale and spread this model. However, I would say that this model or of care could not have happened without the strong partnership and in-kind contributions, but all the partners that you've seen on the first slide, and I would say including home and community care as well. So strong partnerships and in-kind contributions are key. This also speaks to the potential of sustainability of this kind of model, because so far we've basically just reorganized existing services and resources. Other elements of success include tenant engagement and trust. It's key. And I think I'm speaking to the choir, so I won't say more about that. The data-driven approach was very, very helpful in helping us focus where we need to go and what do we need to do or to focus on in our implementation. It also was very helpful that we together mutually established structures to help us work as one team with a unified message and branding. Also, the proactive approach to identifying care needs really proved itself. It's not enough to wait for the population to be there and wait for the population to approach you. They don't always know what they can ask you for. So that proactive approach is really paying off. And we also, because of that proactive screening, we're able to then cluster care around tenants with common needs. And that, in our view and experience so far, has really helped reduce cost of care and the efficiency or the accessibility to care. But we are also working to more drilling into that and evaluating that in more depth in the near future. And of course, the local service delivery really helped with access. So in the interest of time, I will stop here, but that has been kind of our journey so far with the neighborhood care team. That has been very rewarding. Thank you.
Thank you so much. Amazing examples. Throughout these examples, I'm hearing the message of partnerships, like the OHTs are great for collaboration and partnerships. I'm hearing a message about each of the teams using data. Of course, that was our focus today, but still, that's great that you're using data to sort of help drive your focus in your decision making. And finally, I love that in the co-design phase that each of the teams here talked about engaging with their communities, involving patients, family, caregivers, or community members in, finding out about their needs or asking them how they want the services to look like in the future. So that's really, really encouraging. Thank you so much to our presenters. So now, if you want to take down the slides, Melissa, yeah, we're going to do some Q&A time. I think we can take down the slides, and if anybody wants to come on camera, that's great. Not mandatory, but you're welcome to. We have a couple questions in the chat that we can go to first. And if anyone feels brave and wants to put up their hand, I can unmute you and you can also ask your question. But we had one question early on. I think for you, Brenda, unattached. Were unattached patients involved in your campaign? Are they able to be referred for screening?
Yeah, thanks for the question, Janine, and thanks, Monroe, not Ross, Monroe Ross. Thanks for your question. For that, I think I replied incorrectly. So, for sure, the ad campaign, what it does is it has QR codes, and so at 3 bus stops and at we have LRT in our region. So at our LRT stops and even on the bus, those ad campaigns have QR codes, and those QR codes takes them to the Grand River Regional Cancer Center website. And on there, there's a bunch of information, including how unattached patients can receive screening services. Now, of course, those that are attached. It's much easier. So, you know, just because we have information doesn't mean it's the ideal, but you know, it does provide information on how they can access services without a provider. Thanks for the question.
Thanks, Brenda. And just in follow-up, my question is, did you partner with the regional cancer screening programs then at all with this, the QR codes and whatnot?
Yeah, absolutely. So Grand River Regional Cancer Center and our primary care lead, you know, was instrumental in all of this work. We actually have a working group that's just focused on cancer screening, and they're active members in this work. So yes.
That's great. Thanks, Brenda. And then Sarah Grace, I know you answered in the chat, but maybe we can just revisit. There was a question about sort of moving the ALC indicator. So maybe do you want to speak briefly to that?
Sure, yeah. So as I mentioned, so the CFS form that we're using has just started with being implemented or being used by specific primary care providers and programs that have kind of raised their hand and are interested in starting. And now we're in the process of rolling that out to all of our primary care providers and our programs at the Family Health Team and Community Health Center to start to kind of build up that population registry. So I'm hopeful and suspect that we'll continue to see a trend with connecting that to our ALC indicator as it's kind of used and adopted by more primary care providers in a longer term. But that's certainly something that we're continuing to monitor with the expansion and use of the CFS tool.
Thanks.
And then I think, sorry, just one other thing that I'll add. I think part of the exercise of collaborating with partners from across the system and kind of identifying different programs and connecting those to the CFS tool has ultimately also kind of risen more awareness of the different programs and services that are available in the community and how to refer to them and how to access them. So that's certainly been kind of an unintended benefit, if you will, of the exercise and the program, is that there's been some uptake and increasing referral volumes to other community programs that otherwise may have not been accessed.
A balancing measure with a positive slant to it. Often they're the negative ones that we're tracking. So that's great to hear. Any other questions? You can feel free to put up your hand, unmute yourself, put it in the chat for Mike or the presenters or the CEQIP team. Mike.
It's not so much a question as a comment. What I noticed in all the presentations, which I thought was terrific, was that your focus wasn't necessarily on the actual CEQIP indicator. It was about improving care for a population of patients of which, if you improve their care, the CEQIP indicator would automatically move. And I really want to applaud that sort of orientation, because you're obviously by addressing the larger group, you're impacting more patients while impacting your CEQIP indicator at the same time. So I just think that was a terrific foresight on all of your parts.
That's great, Mike. And I did note in Brenda's presentation, you had the one slide, Brenda, with all your process measures, like you list, you know, so Maggie and I, when we do the drop-ins and people come to learn mainly about the navigator and how to use the tool, but I know, Maggie, you always are showing people where they can put their process measures in. So we like to hear about that too, right? Like, so these are the measures that are, you're measuring, you know, smaller things on the ground against the actual change idea. You know, you likely see change there quicker than you're going to see change in this big dot ALC indicators, someone in the chat noted, like that one's really hard to move. So that was good to see. Brenda, maybe you would just share like those process measures. Are you just like tracking them on paper, or do you share those in any way, or is it just for sort of the team?
Thanks. And so we have a cancer screening implementation team, our working group that we share there, but they also report up to a larger group that I'll say is like a steering committee. It's not called a steering committee, but you know, for those who are familiar with it, and we report back. We have also included, we have an annual business plan as well that has much more than just our CEQIP indicators, but and CEQIP initiatives. And within there as well, we have included our process measures as well. So for sure, not just on paper, we are tracking them, and more importantly, we're acting on them and reporting them as well.
Thanks. Okay, last chance for questions, guys, while you have your OHT peers on the line. Any questions for any of the presenters today? We have a shy group. Maggie, did you have a question? Is that a clapping hand or a question?
It's a question hand.
Okay.
It's more a general question, sort of to build on the process measure discussion. Is I'm curious to know, because I often hear or have folks ask me at drop-ins, is what are other OHTs doing in terms of monitoring internally because your CEQIP is due, you know, by April 1st, and then you don't really need to sort of make any other changes or updates to it till we launch again. So I often get questions around how are people monitoring it in between that time period? Is it like a quarterly? So I'm just curious, open it up to anyone who wants to comment on how are they monitoring, maybe process measures, or maybe your big dot CEQIP indicators or other indicators. Just do people have standard, like a process for that?
I don't know.
Holly? I think Holly's
yeah.
got her hand.
Holly,
I can
great.
maybe
Yeah.
share what we do at North Toronto OHT. So we, noting that the CEQIP indicators are big dot system level indicators that have taken years to move, and oftentimes our small tests of change won't necessarily impact those big dot indicators. What we've done is created impact indicators that we regularly measure and monitor. And so for each area of focus, we have kind of one indicator that sums up the work that we do within our change ideas, that we kind of have displayed on a Power BI dashboard. And so it's easy access for us to be able to measure and monitor those. And then quarterly, biannually, we do kind of do like a CEQIP progress update to be able to see our impact within kind of those smaller tests of change. To see if there has been any movement related to that area of focus, but an indicator that we believe we can actually move there. That's how we approach that.
That's great, Holly. Thanks. Thanks so much. Okay, well, this has been great. We'll try to get more attendee questions going in the next meeting, but I still think we did a good job getting the information and the sharing out there. On that note about the measures, I'm going to launch a poll while Melissa, maybe you can pull up the slides again, sort of our extra slides, our outro slides. And I'm going to launch an exit poll, which is going to ask you how likely you might use one idea or concept from this session moving forward, but also what topics you might like to learn about in a future CEQIP COP meeting. One of them sort of related to that question Maggie asked at the end around the family of measures with the focus on process measures. So let us know what you might like us to focus on. If you have other ideas that are not on the list, you can type them in the chat. And thank you to all the speakers today. Is the poll, did you see the poll, Maggie? I launched it. No? You do? Some do, some don't. Oh, hang on one second, guys.
It's gone now, Jeannie. It was only up for a short time, so I don't know if you want to put it up again.
Okay, let me see. Relaunch poll. Continue.
Yeah, there
Okay,
it is.
it should be launching again. Sorry about that, guys. Okay,
I think you have to scroll down a bit if you can't see it on your screen.
yes, you might need to scroll down. So answer the first question and then scroll down and do the second one. So yes, we will share the slides. So the slides from today will go on our CQUIP shared space. Maggie put the link in the chat. So that's part of the wrap up today is to remind you, join our CQUIP community of practice. It's an online space where you can post your questions, get answers, see the peer learning templates. So we're getting lots of the team sharing their work on there, which is really great. Attend one of the drop-ins. Maggie is there to help coach people. If you have questions about the navigator or even like QI questions, we can answer those too. So make sure you sign up and attend one of the drop-ins before your CQUIP is due by April 1st. You can always look at other people's quips to get ideas. So the query quips, the tool is linked into this deck here. And again, if you have trouble or not sure how to use it, you can reach out to the QIP inbox and we can help you. All the resources are available on the shared space. And also when you log into Navigator, you'll see the links there. Next slide, did I miss anything, Maggie, in terms of the resources?
No.
Okay.
I just put because I realized the peer learning templates, we didn't have a folder. So I just created a folder in the attachments so that we'll put the peer learning templates in there as well. And then we can put the slides. Yeah.
That's great. Yeah. So join the shared space, get access to the dashboard, attend an upcoming drop-in, connect with Mike or any of the other coaches if you want to have some help, learn more about this population health management approach. And we're looking forward to seeing your submissions in April. Thanks so much for your time, everybody. Have a great night.